So I'm going to go ahead and start. I know people will probably continue to join, but I want to go ahead and start the webinar. I'm Dr. Carol Kirkpatrick. I am a clinical scientist with Midwest Biomedical Research. Currently, I'm also adjunct faculty at Idaho State University. I am a former PLA, Pacific Lipid Association president. So we are hosting the Practical Pearls today. So really want to highlight the Pacific Lipid Association. And our speaker today is the current president of the PLA. And so just a couple of things before I introduce Dr. Wilkinson. The Practical Pearls is a new webinar series that the NLA has started. There actually is a website. So we're recording these Practical Pearl webinars, and they will be posted on that website for the NLA. So, if you want to go back and listen to this webinar today that we're hosting, as well as the future ones, they will be held every second Thursday of each month, and the chapters that are across the United States for the NLA will host each month. So I believe this is the inaugural webinar, and we have as our presenter, Dr. Michael Wilkinson, which I mentioned, is the current PLA president. He is also a board certified, he's board certified in internal medicine, cardiovascular medicine, echocardiography, and clinical lipidology. He's a clinical lipid specialist, board certified. He directs the advanced lipid treatment program at the UC San Diego Health, and he is also serving on the NLA board of directors. I really want to highlight that he currently became a new program was just funded at UC San Diego Health, UC San Diego rather, and Dr. Wilkinson serves on the steering committee of the Bioinformatics, Epidemiology, and LPA Center for Research and Innovation, also called Beacon. And I believe you will discuss that a little bit later in your presentation. His research interests include lifestyle change and novel drug therapies, with patients who are at risk for cardiovascular disease, and focusing on familial hypercholesterolemia and lipoprotein (a), LPA. And he actively teaches and mentors students at UC San Diego Health, and he received 2 years in a row excellence in outpatient specialty teaching. So I'm very honored to moderate this session today. Please put your questions in the Q&A tool throughout the webinar, and I'm going to turn it over to Dr. Wilkinson to tell us about lipoprotein (a).
Thank you, Carol. Thank you for that kind introduction. And it's been my privilege to work with you through the Pacific Lipid Association and the NLA. And I'm really grateful for this invitation to speak during this Practical Pearls focused on lipoprotein (a). So as you mentioned, I'm the director of our lipid clinic at UCSD, and seeing patients for elevated Lp(a) is a really big part of my everyday. And what I want to do during this presentation is give you an update on what we know about lipoprotein (a) and how to translate some of that to patient care. So I really do want this to be a very practical talk, and I hope that it's really clinically useful. As you mentioned, please, for the audience, put questions in the Q&A, and we'll save some time at the end to address those. So thanks again for having me today. So as I mentioned, we will go through lipoprotein (a) in detail. We'll talk about its structure, the things that make it unique, the way that we measure lipoprotein (a), and what we know about its role in ASCVD and calcific aortic valve disease. And as I said, I want to make this really clinically relevant. I'll talk about how to approach and manage patients with elevated Lp(a), and we'll talk about the future. So we'll review some of the clinical trial data around Lp(a) lowering targeted therapies, and talk about what's next for Lp(a). Let's start with a case. So I'm sure just about everybody on this call already knows about Lp(a) and its association with cardiovascular risk. It is a inherited causal risk factor for cardiovascular disease. And we'll talk about ASCVD and calcific aortic valve disease as those diseases most tightly linked with elevated Lp(a). In my clinic, let's say we have a 45-year-old man of South Asian ancestry. He's got a family history of premature cardiovascular disease. His Lp(a) is 100 milligrams per deciliter, or 250 nanomoles per liter. He has no history of ASCVD, but he's very concerned about his risk. He's seen the cardiovascular disease that's affected his family members at a young age, and he's worried about his own risk. So how do I think about Lp(a) in this context? And that's one really important thing, is to take the patient as a whole, look at the Lp(a) related risk, but also other risk factors for cardiovascular disease, his family history, and then let's go through his lipid panel, his blood pressure, and other aspects of his history. So not only does this patient have high Lp(a), but he has other aspects of dyslipidemia that increase his risk for cardiovascular disease. His LDL cholesterol is elevated at 171 milligrams per deciliter. His triglycerides are elevated at 220 milligrams per deciliter. He has low HDL cholesterol at 30 milligrams per deciliter. Elevated non-HDL cholesterol, higher than we might typically expect for his LDL cholesterol, but not surprising given this profile of low HDL, high triglycerides. And then elevated blood pressure. No history of diabetes or smoking. So if we start out using a calculator to estimate 10-year risk and as best we can lifetime risk, this patient has a 10-year risk by the pooled cohort equations for MI or stroke of 5.3%. So that's over 10 years, and a lifetime risk as high as 50%. I have the image of lipoproteins on the screen to remind us of how lipoprotein(a) fits in with the rest of this patient's lipids. So when we're talking about Lp(a), we're talking about an ApoB100 containing lipoprotein that is structurally very similar to LDL, in size very similar to LDL. But when you look at somebody's risk, lipid-related risk for ASCVD, it's important to take all of these ApoB containing lipoproteins into consideration. So not only is his LDL cholesterol high, but his non-HDL cholesterol is high. And the non-HDL-C is giving you a picture of what's going on in these other ApoB containing lipoproteins, the cholesterol content of VLDLs, IDLs, as well as LDL, Lp(a), everything contributing to cholesterol when you subtract out the HDL cholesterol. So that LDL is important. The non-HDL cholesterol is very important in this case, especially as I mentioned, given that it's especially elevated, the lipoprotein(a). So a lot of lipid-related risk, and that's one thing that I want to highlight, is that we need to think about Lp(a) in this context for our individual patients. This patient has now a lot of risk factors. He has atherogenic dyslipidemia with his low HDL, high triglycerides, high LDL, high Lp(a), elevated blood pressure, family history of premature disease. So a high-risk patient, and maybe his 5.3% 10-year risk could even be an underestimation of his true risk. And we'll get into that a little bit more and how we might further risk stratify this patient. But let's take a deeper dive into Lp(a). So Lp(a) was first described in 1963. The LPA gene was cloned and sequenced in 1987. And we really started to see growing interest in Lp(a) around 2009. We really have this series of epidemiologic and genetic findings that really have solidified this causal relationship between Lp(a) and cardiovascular disease from that time. This is reflected in consensus statements and guidelines for professional societies. In 2010, the European Atherosclerosis Society consensus statement recommended screening for Lp(a), and screening recommendations have evolved over time, and we'll talk about that in a few slides. But I want to spend a minute here on the structure of Lp(a) because this is really an important part of understanding what makes Lp(a) unique among the lipoproteins that we worry about when we're thinking about our patients' risk for cardiovascular disease. So I already mentioned some of the ways in which Lp(a) is structurally very similar to LDL. You can see that depicted here with that ApoB100, that red surface apolipoprotein on each of these particles. But one of the things that's unique about Lp(a) is that long structure that you can see hanging off the side of the particle. That's Apo-A or Apo(a). And this is one of the very unique aspects of Lp(a). It's a protein that's covalently bound to ApoB100, and there's a lot of heterogeneity in the length of the Apo-A. This creates different Lp(a) isoforms. You might have heard that term before. The isoforms of Lp(a) have to do with the number of Kringle 4 subtype 2 repeats on Apo-A. And that's genetic. So our LPA gene dictates the number of Kringle 4 subtype 2 repeats in this protein. And you can see that that's the variable region on that protein. You can have anything from, in the top left corner there, 4 of those repeats. You can have 8, 24, 40. There's a lot of heterogeneity that creates this variety of Lp(a) isoforms. And this is really important to understand because it really impacts things like our ability to accurately measure Lp(a). There's a relationship between isoform size and blood levels of Lp(a), whereby smaller isoforms tend to associate with higher blood levels of Lp(a). Larger isoforms tend to associate with lower blood levels of Lp(a). So that's one of the important unique features of Lp(a). Another is OXPL, or oxidized phospholipids. Oxidized phospholipids are carried by other proteins in the body, but Lp(a) is the major lipoprotein carrier of oxidized phospholipids. And these are pro-inflammatory and really give Lp(a) some additional abilities to promote inflammation and also trigger a cascade of events in aortic valve leaflets that increases risk for aortic valve calcification. Finally, you can see in the bottom corner of this slide the structure of plasminogen and how similar that is to the structure of Apo-A. This homology with plasminogen is likely the explanation for anti-fibrinolytic properties of Lp(a). So plasminogen gets converted to plasmin, which is important in breaking down clots. Because of the homology between Apo-A and plasminogen, there's evidence to suggest that lipoprotein A might get in the way of plasminogen activity, especially at high levels, and thereby Lp(a) can exert these anti-fibrinolytic effects, get in the way of the body's ability to break down clot. So with these unique features of Lp(a) in mind, we can talk a little bit about how we measure Lp(a) and some of the challenges that come from the structural heterogeneity in Lp(a), especially that Apo-A isoform issue that I mentioned. So this is a list of Lp(a) measurement issues. I think from a practical standpoint, one big picture topic to understand is that there are 2 ways in which Lp(a) levels are currently reported: the molar versus mass assay. And the molar measure of Lp(a) is in nanomoles per liter. The mass assay is in milligrams per deciliter. These are very different ways of measuring Lp(a), and it's important to know that there is not an easy way to convert between units. You can use a factor of about 2.2 to 2.5 to go from mass to molar. multiply mass to get molar, for example. But really, these are different, very different assays and ways of measuring Lp(a). Both are affected by the heterogeneity in Lpa structure and isoform, and that's important to acknowledge. We do suggest, whenever possible, to perform Lpa measures using a molar assay. But I think one important takeaway is that whether you have access to a lab with a molar assay or a mass assay, we just need to be measuring Lp(a) more frequently. It's important to acknowledge some fluctuations that occur in Lp(a) measures, both related to some of the limitations of these assays. So if you are to repeat Lp(a) measures in an individual patient, you will see some fluctuation. Lp(a) levels are primarily genetically determined, but there is some variability that we see, and part of that is related to measurement. Part of it is related to true intra-individual Lp(a) fluctuations. So important to understand some of these limitations, but at the end of the day, use the measurement that you have access to. If you have patients who have elevated Lp(a), either by a molar or mass assay, we know that their risk of cardiovascular disease is increased. So it's important just to measure and get that Lp(a) value either way. But this gives you just one example of how that ApoA isoform can affect the way that we measure Lp(a). If you have, for example, in panel A, an ApoA isoform sensitive assay that's binding to the copies of the Kringle 4 subtype 2 repeats, you can imagine that the measurement is going to be affected by the total number of those repeats. That if you had a small ApoA isoform, while those isoforms, small isoforms, are associated with high Lp(a) concentrations and high cardiovascular risk, your isoform sensitive assay may underestimate the Lpa concentrations. And you may see the opposite effect with large ApoA isoforms. So in the future, what we need are these isoform insensitive assays. Panel B just gives you one example. If you had an antibody that was binding only to Kringle 5, which is a unique Kringle, across ApoA isoforms, not going to vary like the Kringle 4 subtype 2 repeats, then you could truly get this measurement where ApoA is recognized only one time for each particle, and you can get a very accurate measurement of Lp(a) in molar units. When we think about Lp(a) as a particle, and we think about its structure and these characteristics that make it unique, we have data now to suggest that on a per particle basis, Lp(a) is more problematic, potentially more problematic than an LDL particle. So if you look at Lp(a), ApoB, and LDL, ApoB, if you had both at a molar concentration of 250 nanomoles per liter, it's really all those things that we just talked about that make Lp(a) more atherogenic at the same number of particles as LDLs, LDL, ApoB. Pro-inflammatory oxidized phospholipids, a pro-inflammatory proteome, a smaller, more dense particle with those antifibrinolytic effects. Part B of this figure shows you what most people experience in that LDL ApoB or LDL particles are usually a lot more abundant than Lp(a). So LDL is a very important target of therapy. Most people have this overabundance of LDL particles, and that's where a lot of ASCVD risk comes from. But you can imagine that if on a per particle basis, Lp(a) is higher risk than LDL, if you're somebody with very high Lp(a) levels, then those particles are going to be carrying more of that risk, put you at higher risk for ASCVD on a per particle basis. That's going to be more problematic if you have more of those Lpa particles in circulation. So who should we test for Lp(a)? And as I mentioned, these guideline recommendations for screening have evolved over time. This is a complex table because you can see how Lp(a) risk thresholds have evolved, how major recommendations have evolved over time, and there's been consensus around testing people who are at increased risk for ASCVD, for example, with a family history of premature ASCVD. But the National Lipid Association just updated recommendations for LPA testing last year to really simplify this and suggest that we measure Lp(a) at least once in all adults and selected high-risk children. And you can see how Lp(a) levels can be used to think about risk. We use Lp(a) at or above 50 milligrams per deciliter or 125 nanomoles per liter as an indicator of high risk, of high Lp(a) related risk for cardiovascular disease. And low risk is less than 30 milligrams per deciliter, less than 75 nanomoles per liter. And there is this gray zone or intermediate area, and you'll find patients with Lp(a) values in this range. And I think this is where repeat testing for Lp(a) can be especially important. This recommendation from the NLA includes consideration for repeat testing for individuals who have Lp(a) measures in this gray zone, because there is some variability, as I mentioned, in testing and in intra-individual levels of Lp(a). So if you repeat a test in the gray zone, you might find that somebody's truly more in the high-risk Lp(a) zone when you repeat testing for them. But the NLA recommended that once we test for Lp(a), currently we should be taking a more intensive approach to risk factor management. We should be performing cascade screening. This is really important given the genetic basis of Lp(a). We can diagnose family members with high Lp(a) and start treating their risk factors for cardiovascular disease earlier in life. And we'll talk about the role of lifestyle modifications and select pharmacotherapy. And we'll talk a little bit about apheresis as well. So we already talked a little bit about how there are features of Lp(a) that contribute to these various forms of cardiovascular disease risk that are causally associated with high Lp(a). So Lp(a) is pro-atherogenic. It promotes atherogenesis and vascular inflammation. It's also uniquely a driver, lipoprotein driver of aortic valve calcification. And that has a lot to do with the oxidized phospholipid content of Lp(a) and pro-inflammatory effects that trigger this downstream cascade leading to aortic valve calcifications. And we talked about risk for thrombosis, specifically arterial thrombosis is where we have the best evidence to suggest a causative relationship between high Lp(a) and thrombotic risk. And as you can see in the image, that has to do with potential competition between plasminogen and ApoA when there's very high Lp(a) levels, whereby Lp(a) can exert antifibrinolytic effects that promote thrombosis. Lp(a) is highly prevalent, is a highly prevalent causative risk factor for ASCVD that we do not test for frequently enough. We estimate that about 30% of people have elevated Lp(a) above about 25 to 30 milligrams per deciliter, and that about 20% or 1 in 5 people have Lp(a) above 50 milligrams per deciliter or 125 nanomoles per liter, in that range where we see a clear association with risk. And this is a distribution of Lp(a) values from the Copenhagen General Population Study. Lp(a) does tend to have this skewed distribution in the population. You can see in this case how most people have an Lp(a) less than 50 or especially less than 30 here in that normal range, but you have about, as I mentioned, 20% of individuals here with Lp(a) above 50 milligrams per deciliter. It's important to acknowledge that the distribution of Lp(a) is different in different populations, different people with different ancestry. For example, we do find elevated Lp(a) more often in individuals of South Asian ancestry, in Black individuals. Lp(a) related risk is high across the board. The risk attributable to Lp(a) has to do with the Lp(a) level itself, regardless of the distribution in a given population of patients. But just know that we need to be looking, especially for certain individuals, as I mentioned, to be at risk for having high Lp(a). We need to do a better job of screening across the board. But this is what I mentioned, this evolution of research over time to really solidify this causal relationship between Lp(a) and cardiovascular disease and establish a linear relationship between Lp(a) levels and cardiovascular disease risk. And we see the same results, whether you look at a meta-analysis of epidemiologic studies with this linear increase in risk as Lp(a) levels rise, because the LPA gene really dictates the bulk of Lp(a) levels. This is a primarily genetic disorder. You can use Mendelian randomization and genome-wide association to establish a relationship between Lp(a) and risk, and you can see there as well this linear relationship between Lp(a) and cardiovascular disease risk. And we've started to identify more and more the genetic basis of Lp(a). We've identified certain SNPs, for example. You can see in this slide in the top right-hand corner, in certain populations, especially in those of European ancestry, but we need more work in this area to better understand more of the specific SNPs or genetic drivers of elevated Lp(a) and cardiovascular risk. Part of understanding the pathophysiology of Lp(a) is understanding the role, as I mentioned, of oxidized phospholipids and those things about Lp(a) that promote disease beyond atherosclerosis. This is an example of data demonstrating a pro-inflammatory risk associated with high Lp(a). This is a study using PET imaging of the aorta and carotid arteries, and you can see an increase in inflammation within the arteries among individuals in this study with elevated Lp(a). There's also increased activation and transendothelial migration of monocytes into the vascular wall in the setting of high Lp(a). And that's, as we know, a key step in the development and promotion of atherosclerosis. So aspects of Lp(a) that make it unique and are associated with some of its unique features, such as its high content of oxidized phospholipids. And oxidized phospholipids are also likely responsible for triggering this cascade of events in aortic valve leaflets, promoting calcification of aortic valve leaflets. You can see this cascade coming from the oxidized phospholipids on ApoA, leading to an increase in the activity of vascular interstitial cells, osteoblasts. There's calcium phosphate deposition and mineralization of the aortic valve leaflets. So really an important aspect of disease associated with Lp(a), and you will see more and more about this in the future as we learn more and more about this relationship between Lp(a) and aortic valve disease. Aortic valve disease progression is accelerated in the setting of high Lp(a). You can see that here in those with Lp(a) levels in the third tertile, an increase in the progression rate by peak velocity through the valve that was higher in the setting of high Lp(a), and probably especially important in young people. You can see in the panel C, when you're less than 57, if you have high Lp(a), you're at much higher risk of faster progression of aortic valve disease. We're likely that high Lp(a) plays a bigger role in driving the progression of calcific aortic valve disease. So what about imaging and Lp(a)? We talked about measuring blood levels. We talked about the risk of calcific aortic valve disease. What do we know about imaging and looking for plaque when it comes to LP little a. I think that from a practical standpoint, it's important to acknowledge that coronary imaging is a very useful tool for risk stratification, and that includes for patients with high LP little a. Now, LP little a is an independent risk factor for cardiovascular disease, but as you can see in data from MESA and the Dallas Heart Study, that while both LP little a and calcium scoring are independently associated with risk of ASCVD, when the two occur together, risk is even higher. You can use both. You can use both together to get an even better understanding of somebody's risk. So you can see in every case where LP little a is higher and or there's a non-zero calcium score, or the calcium score is increasing as a measure of calcified plaque in the coronary arteries, risk of ASCVD is increasing significantly. There's been a lot of interest recently in whether calcium scoring and calcified plaque really sufficiently captures coronary artery disease in individuals with very high LP little a, and that comes from data like I'm presenting here from the Miami Heart Study using coronary CT angiography, which is able to look at not only calcified but also non-calcified plaque in the coronary arteries. And you can see that when patients, statin-naive adults who are asymptomatic, underwent a coronary CTA, those with high LP little a were more likely to have plaque in their coronary arteries, and more of it was in the form of low attenuation plaque. There were more of these high-risk features that we can identify in coronary artery plaque by coronary CTA among those individuals with high LP little a. And that's been reported in other studies. So a greater prevalence of low attenuation plaque, for example, in those with high LP little a. And you can see in the bottom corner of that panel, the proportion of those with a calcium score of 0 having any plaque. So even if you had a calcium score of 0, if you had a high LP little a, you were more likely to have some plaque. That would be non-calcified plaque in this case with a calcium score of 0. So maybe LP little a is more likely to promote the formation of non-calcified plaque and plaque with higher risk features, something that's going to be very important to examine in ongoing and future studies. So what do we do in our case? So as I mentioned, we start out with thinking big picture for this patient and his ASCVD risk. We perform some estimation of risk, 10-year risk, for example, using the pooled cohort equations. The recommendations for using the pooled cohort equation come along with a recommendation to consider what are called risk-enhancing factors, and LP little a above 50 milligrams per deciliter is included on that list of risk-enhancing factors that we have to at least qualitatively incorporate into our assessment of this patient's risk. Knowing that LP little a increases risk for atherosclerosis and calcific aortic valve disease, I think it's reasonable to be looking for evidence of these diseases on exam, but that's, we have to admit, an insensitive way of detecting some of these diseases, especially in the early stages of development of these diseases. Consider coronary artery calcium scoring. So I do think that would be a very reasonable approach in this patient. In recommendations for using coronary calcium scoring, we're encouraged to consider using it for risk stratification in those with a borderline or intermediate 10-year risk. He had a 10-year risk estimate in the borderline zone. I think using a calcium score, we know now that has independent prognostic abilities in patients, in addition to the use of LP little a in thinking about risk. So let's say his calcium score is 20. Not severely elevated, but I want to emphasize the fact that while this may be mild calcification on a scale like I have depicted in those images there of the coronary arteries, a calcium score of 20 at age 45 is high. And that's one of the most important things we need to be thinking about when we interpret calcium scoring, is not only the absolute score, but the age, and other characteristics of the patient that really tell us a lot about this individual's lifetime risk of cardiovascular disease. Having a calcium score of 20 at age 45 is a marker of increased lifetime risk. So we need to be treating this patient to reduce his risk. So how do we treat Lp(a), or how do we treat patients with high Lp(a) today? I've mentioned how Lp(a) is primarily genetically determined by that LPA gene, but this slide summarizes some of the things that we know impact Lp(a) that are currently available. So we use statins to lower ASCVD risk in patients with high Lp(a). The patient I'm presenting in this presentation should be on a statin. He needs to start a statin. But we do need to acknowledge that there is convincing evidence that statins can increase Lp(a) levels up to about 10, up to maybe 20%. That is a very variable response with statin treatment. And what I'd like to emphasize is that statins are a very, very important part of lowering ASCVD risk, lowering LDL cholesterol and ApoB, and we should not withhold statins just because there could be some increase in Lp(a) levels in these patients. We don't know where the balance is between the risk reduction with LDL and ApoB lowering and more modest elevations in Lp(a) with statin treatment. But given the potent ability of statins to lower LDL, ApoB, and ASCVD risk, we really need to prioritize the use of statins in these patients as a part of their comprehensive ASCVD risk reduction. As I mentioned, Lp(a) is not quite as static as maybe we think. It is mostly genetically determined, but things like chronic kidney disease, including nephrotic syndrome, increase Lp(a) levels. Inflammation, systemic inflammatory diseases, for example, are associated with an increase in Lp(a) levels. A low-fat diet, specifically studies that have looked at the replacement of saturated fat with carbohydrates or trans fats, have seen some modest increases in Lp(a). We don't see the increases in Lp(a) when you replace saturated fat with other healthier fats, mono and poly unsaturated fatty acids. So something like a Mediterranean diet or heart healthy diet style that includes healthy fats is probably a good option for these patients. In terms of tools for decreasing Lp(a), niacin is able to lower Lp(a) by about 20 to 30% in a dose-dependent fashion, but there aren't data to suggest that using niacin reduces risk of ASCVD. No consistent or convincing evidence that niacin can lower cardiovascular risk in patients with high Lp(a), and there are potential side effects associated with the use of niacin. PCSK9 inhibitors, on the other hand, are generally better tolerated, some risk of injection site reactions, but they can lower Lp(a) by up to 15 to 30%, mostly LDL cholesterol lowering drugs, but do have this ability to provide us with some modest Lp(a) reduction. I'll talk about apheresis in a couple of slides, but it is a tool that we have access to currently that is effective for lowering Lp(a). But as we'll discuss toward the end of the presentation, it's targeted Lp(a) lowering therapies that are the most potent, and those are in clinical trials, but we'll talk about where things stand with the development of those targeted Lp(a) lowering therapies. I do want to emphasize that healthy lifestyle and management of other cardiovascular risk factors is very important in reducing risk among patients with Lp(a). This is some modeling that was done in the EAS consensus statement for Lp(a), looking at how your baseline risk for ASCVD events interacts with your Lp(a) level. And you can see along the x-axis, as you have more and more risk factors for cardiovascular disease, if you add to that higher and higher Lp(a) concentrations, you get this progressive increase in risk. This is lifetime risk of ASCVD events. So the thought is that if you can move yourself into some lower baseline risk category by treating other risk factors for cardiovascular disease, maybe you will be lowering your lifetime risk of cardiovascular disease, although you will still be facing that increase in Lp(a) related risk if your Lp(a) level is high. What do we know about PCSK9 inhibitors and their ability to lower Lp(a) and risk of cardiovascular events? Well, we have to be careful about that. I mean, PCSK9 inhibitors, as I mentioned, are able to lower Lp(a), but we have only limited data to suggest that there is risk reduction associated with that 20-25% reduction in Lp(a). These are post hoc analyses from PCSK9 inhibitor clinical trials, Odyssey outcomes on the left, the Fourier trial on the right. You can see that as you get to higher and higher levels of Lp(a) in these very high risk cohorts of patients with established ASCVD who are treated with PCSK9 inhibitors, for example, in Odyssey outcomes, when your Lp(a) was at the 75th percentile, we can attribute some of that absolute risk reduction for cardiovascular events to the reduction in Lp(a). In the Fourier trial, if you were treated with evolocumab, you can see that there was greater benefit to that if you were in a group with higher Lp(a). So I think that the takeaway currently is that we have cardiovascular outcomes data with PCSK9 inhibitors. We already know that they are an important tool that we have for lowering LDL cholesterol, ApoB, and cardiovascular risk. We have cardiovascular outcomes trials and secondary prevention from Odyssey outcomes and Fourier. We should be using these drugs. And if there is some part of risk reduction that is occurring because of the impact of these therapies on Lp(a), great. Although we have, as I'm presenting here, these post hoc analyses to support that. And again, what we need are the large randomized control trials of potent Lp(a) lowering therapies to better understand the potential for intensive Lp(a) lowering to reduce risk. Finally, in terms of existing therapies, a note on lipoprotein apheresis. So, lipoprotein apheresis removes ApoB-containing lipoproteins, including Lp(a). This is an example of dextran sulfate-based lipoprotein apheresis, where the negatively charged dextran sulfate on cellulose beads binds to the positively charged ApoB on this entire family of ApoB-containing lipoproteins, including Lp(a). And it's important to know that lipoprotein apheresis is something that we do consider for high-risk patients with high Lp(a), and that the indication for using apheresis to treat individuals with elevated Lp(a) were updated earlier this year. You can see the Group D recommendation on this slide includes Lp(a). The Group C indication for heterozygous FH by LDL cholesterol levels and history of ASCVD was updated. But in the case of those with familial hypercholesterolemia and elevated Lp(a), the requirement for an LDL cholesterol over 100 milligrams per deciliter to qualify for therapy was removed in this January update. And so we really should be looking for individuals, high-risk patients with established cardiovascular disease who might benefit from starting apheresis. One of the limitations around the studies of apheresis for this indication is that we really are relying on retrospective and observational data. However, you can see when you look at especially larger studies, pooled data, I'm just presenting some of the data from the US and German experience with lipoprotein apheresis. But if you look at that bottom row, when we get up to a pooled sample of 930 individuals, we're comparing risks of major adverse cardiovascular events, or MACE, before versus after the initiation of lipoprotein apheresis, which is often performed once every 2 weeks to remove those lipoprotein particles from circulation. But in the setting of either normal LDL-C and high Lp(a), or both high LDL-C and high Lp(a), when you compare MACE pre versus post the initiation of apheresis, there is a significant reduction. So with that in mind, where are we heading with Lp(a) therapeutics? Most of those that are in clinical trials are RNA-based therapies, either an antisense oligonucleotide in the case of pelacarsen, or siRNA therapies such as olpasiran, lepidisiran, zerlasiran. I'm going to present some of the phase 2 trial data from these RNA-based therapies, but know that they all work by getting at that ApoA, the LPA gene and its product, the ApoA that we've discussed. These drugs get in the way of the body's ability to produce ApoA and therefore the assembly of the LPA particles. So phase 2 data with RNA-based therapies have demonstrated that these are potent ways of lowering Lp(a). If you look at the phase 2 trial with the antisense oligonucleotide pelacarsen, you're getting dose-dependent reductions in Lp(a) up to about 80%. In the phase 2 trial with olpasiran, which is an siRNA, you're getting placebo-adjusted Lp(a) reductions up to 101%. And these drugs have been generally well tolerated through clinical trials with risk of some injection site reactions. We've just received this phase 2 trial data with lepidisiran in the alpaca trial, just presented recently and published in the New England Journal of Medicine, which tells a similar story, that an siRNA route of inhibiting Lp(a) is a potent method for reducing Lp(a) levels. And you can see, as depicted here, this dose-dependent reduction in Lp(a), the greatest reductions with 400 milligrams of lepidisiran administered subcutaneously. And the dosing schedule is a little bit different for each of these, monthly, every 3 months, or every 6 months. It depends on the drug that we're talking about, but the consistent finding across these phase 2 trials is a potent and dose-dependent reduction in Lp(a) levels with RNA targeting therapies. And these studies have demonstrated a generally favorable safety profile with some risk of injection site reactions. There's a lot ongoing in this space. Many of these therapies are now in phase 3 trials, phase 3 cardiovascular outcome trial in the case of pelacarsen with the LPA Horizon trial, olpasiran with Oceana Outcomes, lepidisiran is in the Acclaim phase 3 trial. All these trials have slightly different entry criteria, although the requirements have been elevated Lp(a) and a history of cardiovascular disease. The phase 3 trial with lepidisiran that is ongoing is the first to include a subgroup of high-risk primary prevention patients, that is, those without established cardiovascular disease, but with high Lp(a) and other risk factors. Muvalaplin is the only drug on this list that is not an RNA-based therapy. This is a small molecule inhibitor that disrupts the assembly of LPA particles. But all of these in current trials, and very excited to see where things go with this ongoing development of targeted LPA therapies. So finally, just a note about aspirin. In primary prevention, there may be a role for aspirin in those with high Lp(a). The data are really evolving here as well, but we have some suggestion from the ESPRIT trial, as well as the Women's Health Study, that if you had genetic markers, at least, of high Lp(a), such as this SNP RS3798220, you're at higher risk of cardiovascular events. You may benefit more from taking an aspirin every day, but we don't have similar data using Lp(a) blood levels. So still, we have to be cautious about where we recommend aspirin in primary prevention, but definitely there is risk. We've talked about the thrombotic risk, arterial thrombotic risk with high Lp(a), and there's a lot of interest in trying to better identify who with high Lp(a) we should be treating with aspirin for primary prevention. So finally, our patient, we took him through comprehensive risk stratification. We're recommending healthy diet and lifestyle changes. We're starting him on statin therapy. We'll talk with him about the potential risks and benefits of aspirin. PCSK9 inhibitors would be a tool that we might consider if needed for further atherogenic lipid lowering, LDL, ApoB, and we know that it has some ability to lower Lp(a) levels as well. In this paper, we talk about this practical approach to both primary prevention and secondary prevention in the setting of Lp(a). So if you're interested, that's a resource to look through, a practical approach that you might take in your current clinical practice. But we know that Lp(a) is a highly prevalent, causal, and mostly genetic risk factor for ASCVD and calcific aortic valve disease. Everybody should be measured at least once, and we should encourage comprehensive ASCVD risk reduction in our patients with high Lp(a), lifestyle, statin therapy, and we talked about some of the unique aspects of Lp(a) and special consideration for therapies like PCSK9 inhibitors, aspirin, and lipoprotein apheresis. And potent targeted Lp(a) lowering therapies are currently in development, so stay tuned for more results from those clinical trials. Thank you for your attention. Thanks again for the opportunity to be here today. Carol had mentioned the work that we're doing at UC San Diego around Lp(a) and the creation of our Beacon Center for Lipoprotein(a) research. Please feel free to reach out to me with any questions about the center or the work that we're doing, and I'll be happy to take questions from the audience now.
Okay, so I'm going to actually ask you to keep your slide up so that we have several questions and we have a hard stop on the hour. So in case we don't have a chance to answer all the questions, everyone, there is Michael's email address. You can email him directly. Hope that doesn't bring too much traffic to you. So there's a couple of questions related to statin therapy. One is, should we repeat an LPA level after starting statin therapy? And if someone's currently on a statin, should it be stopped before you measure LPA?
Those are both great questions. So the question around whether to repeat Lp(a) testing, I think that, you know, I discuss that with patients and I do let them know about this potential risk to for their Lp(a) to increase with the initiation of statin therapy, but we don't universally recommend repeat LPA testing after the initiation of statin therapy. It doesn't often change management to know that Lp(a) may have increased a little bit after the initiation of statin. And I also think it's complicated because we've talked about all the other things that can impact Lp(a) levels, just some of the limitations in the measurements, other things that can drive ups and downs in Lp(a) levels in an individual. So I also don't I don't insist that patients have had an Lp(a) measure off statin therapy to feel that I know their true Lp(a) level either. I think we need to think about Lp(a) in sort of broader strokes for the most part, that if you have high Lp(a), you have high Lp(a). And if you're in that high risk zone, you can repeat measures and the levels will go up and down a little bit, but your risk is still high. And we need to treat, as I've mentioned, in a really comprehensive way to reduce ASCVD risk, including the use of statin medications.
Very good. So are there any LPA types, perhaps those with high number of Kringle repeats, that are not associated with increased risk?
That's a great question too, because there is a relationship between the Kringle repeats, isoform, size, and blood levels. But they're, at the end of the day, most of the the data that we have is using blood levels, total blood levels of LP little a, not isoform specific data. And so the risk of cardiovascular disease from LP little a is related to the blood level, whether that comes from smaller isoforms or larger isoforms. Probably those with larger isoforms, as I mentioned, are going to be less likely to have very elevated LP little a, but we still think that even if you have larger isoforms, if your blood level of LP little a is still high, that's where the risk comes from. The inheritance of LP little a is in this autosomal codominant fashion where the total blood levels of LP little a come from contributions of both the LPA alleles. So you could have one copy of the LPA gene from one parent that makes more smaller isoform, the other makes more of a larger isoform. And when that all comes together, what you get is your measured blood level of LP little a. And that's the thing that really links to risk.
Excellent, thank you. So a couple questions related to apheresis. And I know we've got like 3 minutes, so if you want to get to any other questions, maybe make this pretty succinct. What are the mechanisms that could explain the dramatic 75 to 95% CVD event reduction with apheresis? And should we treat, these are both from Ellie and Brenton, should we treat more patients with elevated LPA prior to CVD events with apheresis while we wait for FDA approval for new medications? So 2 really good questions about apheresis.
Yeah, that's a great question because there's a lot going on with apheresis. As I mentioned, this is a treatment that clears all of the ApoB containing lipoproteins from the plasma during a session. I mean, it doesn't completely wipe them out, but as I described, you get 60, 70% more reduction in LP little a after an apheresis treatment, along with a reduction in all the other ApoB containing lipoproteins, and you don't impact HDL because that column is very specific for clearing the ApoB containing lipoproteins. There's also data to suggest that other things happen during apheresis, like a reduction in pro-inflammatory biomarkers. All of this could potentially play into potential cardiovascular benefits of apheresis. The problem is that it's been difficult to do any sort of controlled prospective trials with apheresis. So the true magnitude of the benefit, if we were to control it to a placebo intervention in a prospective fashion, is not known with apheresis. And we really only have that current FDA indication among those with high LP little a and FH and a history of ASCVD. So it could be challenging to use it in a primary prevention setting, but I agree that it is a very useful tool that we currently have access to for select patients as we await the results of these clinical trials with targeted therapies.
Okay, so we have like 1 minute left. I don't know if you want to try to squeeze in one more question or just encourage people to email you directly. Would that be okay?
That'd be fine. Or you can follow me online. You can send me messages. Please feel free to reach out because I would love to continue the conversation and also answer, as I mentioned, any questions about the work that we're doing at UCSD.
Yes, there's just a few questions we did not make it to answer. So please do email Michael with those questions. We'll also both be at the scientific sessions in Miami. So if you want to have a face-to-face conversation, then join us in Miami for our 2025 scientific sessions. An excellent presentation today, Michael, as always. And thank you for your time. And everyone, thank you for being with us today.
Thanks again.